you hear me?
Yes.
Yeah, cool. Hello, everybody. Good afternoon. I appreciate Boston Scientific Company and the moderators for giving me a opportunity to participate in this academy. So it's honor to me to present you a case report of BTK lesion. My name is Atmatzas Kirillos, and I'm working in Limb Salvage Center in St. Petersburg, Russia. So let's begin. It's 67 years old male with CLTI, left foot gangrene, Wi-Fi classification 323, third to fifth tooth amputation the day of hospitalization with the standard comorbidities. Performed previous intervention were left common femoral artery endarterectomy 6 months ago and a PTA for P3 popliteal artery occlusion and tibial artery occlusion a week ago. And the fourth postoperative day, the patient began to complain for rest pain. In ultrasound, we found an occlusion of the only one treated tibial artery. So we took him again in our cath lab. Due to a scar after a common femoral artery endarterectomy and a contralateral excess the previous PVI, I decided to make an antegrade excess via SFA under ultrasound control. The patient had severe calcification of the arteries with a moderate to severe MAC score in the foot. You see here patent SFA and popliteal artery with a short occlusion of the anterior tibial artery, flash occlusion of peroneal artery with a recovery of the flow in the middle part, an occlusion of the distal part of posterior tibial artery. And at the second angio, you see it seems that the pedal branch of the peroneal artery is continuous to the pedal artery. So the plan A for me was to recanalize the peroneal artery. So in cases with the severe calcification and flash occlusions, it's very difficult to catch the ostium of the artery with the standard methods like angled guide wire or with the use of support catheter like a vertebral. So after failed standard methods, in our clinic, we use a modified UF or a pigtail catheters. We cut them, as you see in the photo. And this geometry allows us to catch the ostium much easier and have much better support to recanalize the proximal part of the artery and then change the catheter to the over the wire balloon and continue the recanalization. So I recanalized the peroneal artery. Re-entry was in the distal part. You see a short occlusion in the distal of the pedal branch of peroneal artery. It then seems very easily to recanalize it, but unfortunately I failed. I tried many times and I failed again and again. So I recanalized the posterior tibial artery and lateral plantar artery and tried to re-entry, but the unlucky scenario was continuous. For me, unfortunately, I make a control angio, good flow in proximal part of tibial artery and distally, not very good suboptimal result, and surely better than it was, but it's not enough for wound healing. So I want to ask you, what would you do in this situation? In my mind, I had 4 options to finish the intervention, try recanalize the ostium of anterior tibial artery for better inflow, or try retrograde access in lateral plantar artery or an pedal artery. And I want to remind you that the patient have moderate to severe MAC score with calcification of the both pedal and lateral plantar arteries. So, Victoria, it's possible to show the call?
Yes, now call is already in process. So we have 36 people who answered. If you want, I can end the poll and show the results.
Yeah.
Okay, and share the results. You can comment on it.
I have to close my presentation, yeah?
Okay, let me comment. So it is 6% for the first option, 33% for the second, 17% for the third option, and the major 44% try retrograde access and pedal artery.
Oh, good results. It's said that very how to say. Okay, let's continue. I use the same technique. I'm trying to make a pedal access, and as said, Mariana Palena, in this difficult situation, usually I was lucky, and I have done it. We use guide wire and microcatheter only for the retrograde approaches to minimize the risk of bleeding at the end of procedure. Here you see a successful rendezvous technique. And then I put the balloon distally of the retrograde access and made a control angio to be sure that I am in true lumen. Then remove all devices from the retrograde access and made endovascular hemostasis for 5 minutes at least. Good angio results for patient and for me, but not best, unfortunately, because I thought that the pedal branch of peroneal artery was a weak point here. So I continue the procedure. I pass with a guide wire to the plantar arch and to lateral plantar artery, recanalize it, and re-enter it in the posterior tibial artery in the distal part, and took the second guide wire, used the first one for like a kind of roadmap for antegrade passing of the guide wire to lateral plantar artery. PTA with appropriate balloons were performed, and the final angio, the best result for me and for patient, I suppose, with an angio in the frontal side, and the photo of left foot after second two amputation and skin grafting at second day and 14th day. Thank you for your attention.
Thank you, Kirill.
Thank you.
Nice
Very
Thank you.
Yeah.
Congratulations.
Excellent.
Thank you.
This is the pushing to the end, actually. That was good, but not best. And I am looking for the best. This is good. But sometimes it's not possible. In this case, you made it possible. Congratulations.
Thank you. Thank you very much.
Yeah, any comments? And very good thinking of modified catheter, actually. But I should, tell if you cut the catheter from the tip, and it has sharp borders, and it can cause intimal damage. So we should be very, very careful. And one can use Berenstein, for French Berenstein. It is the 90-degree short nose catheter, and will do what you are looking for, actually. If you can obtain a Berenstein, this is what you look for.
Okay, I'll try.
Yeah, thinking was good. Yeah.
Thank you for your advice.
Kirill, let's share something with all of us. What was the most difficult decision for you in the whole procedures? What was the most difficult point for you to decide it, material, approach? What was the patient how amount of the contrast, you know, what was the amount of the irradiation dose? And so let's share your experience with us.
The most difficult stage of the procedure was to try to recanalize the pedal branch of peroneal artery, surely, and the lateral plantar artery. It takes 1 hour, I think. I trying with different guide wires. One of them was broken, and a part of the first guide wire is still here in the pedal branch. The next step for me is to make a decision how to continue, how to help the patient, and surely the pedal access was the more easy access in this situation, because in plantar artery there was a subintimal channel, so it will be very difficult to make a retrograde approach in this situation. And then the other stages of the procedure didn't very difficult for me. It's something usual in our clinic, in our practice. So about contrast, surely we're trying to use as possible to minimize the portion of the contrast. I think it's a procedure for experienced doctors. So and as show us the survey, and most of you are very experienced doctors that you choose the pedal access for the second stage.
Thank you, thank you.
I have a question. I have a question for Kirillos and also for other moderators. In your practice, do you use CO2 angiographies for these patients with renal insufficiency? Because we have many patients with diabetes and impaired renal function. How do you use and how often do you use CO2 angiography just to reduce, let's say, the amount of iodine contrast?
Yeah, thank you. We use the CO2 angiography too in a situation when the renal insufficiency is much severe than in this case. Surely it's not usual. It's not often use of CO2 angiography, but in some cases we use it too. Yeah.
And Dr. Levent, Dr. Vinko, and Madeline,
yeah,
what do you do in your institution?
For us, if the creatinine value is not normal, above 1.3, it's out, or the GFR is above below 60, actually, we always use. But my problem with carbon dioxide is it's not excellent. I've been using it for 20 years. And unfortunately, the technology on carbon dioxide angiography, we have an excellent angiography machine, but we cannot do excellent images with carbon dioxide. Yes, we always use carbon dioxide when the creatinine is high, higher than normal at any point, but we always use iodinated contrast in those patients, especially in below the knee or below the ankle, because the images are not excellent and we need excellent images to decide.
Yeah,
I agree.
That's right. Yeah.
Carbon dioxide, it's a second option in my practice. If I have to use it, I am not satisfied with view of the vessels on the pedal arch, on the ankle level, or below the knee, in the proximal portion of below the knee. Yes, I can accept that. But if I need to be very precise to see something delicate, it's my second options.
Absolutely the same for me. I've used it several times, but below the knee, I think we have much to ask from the CO2.
I think it's a good question for Mariano Palena and Marco Manzi. They
Yeah.
use CO2
Yes,
so much.
always.
Always. So I think it's about the money, you know.
Yeah,
But Marco said once, I was with him, he said, we always start with CO2, but finally we end up with contrast media.
But
Just the same.
the good thing is to reduce also the iodine. So we don't use 200 milliliters, we use 50 milliliters, and it's better for patients. Okay, thank you.
In such cases, I would recommend significant dilution of contrast. And even at a dilution of 1/4, for example, you will have very good images with iodine.
Okay, thank you.